So just what is a prolapse? Vaginal prolapse is a general condition which is caused when structures including the uterus, bladder neck, urethra, rectum, small bowel, or even the vault of the vagina begin to fall out of their normal positions and herniate through the vaginal wall. The pelvic organs and tissues in a woman's body are held in place by a complex support structure, which comprises a network of muscles, ligaments, and skin in and around the woman's vagina. The support system also includes a network of tissues known as the fascia. With time, some or all parts of the support structure may weaken and collapse, which gives rise to the condition referred to as the vaginal prolapse. If these support structures weaken enough and without effective conservative or surgical treatment, they eventually prolapse into the vagina or even through the vaginal opening. Pelvic pressure and discomfort are common symptoms that result from vaginal prolapse. This also usually affects sexual function and other bodily functions, including types of vaginal prolapse include the following: cystocele or prolapse of the bladder. When the vaginal front wall, pubovesicular prolapses, it causes the bladder to prolapse into the vagina, which is called the cystocele. In this condition, the urethra may also prolapse, which is known as urethroceal. When both the bladder as well as the urethra prolapses, the condition is referred to as cystourethritis. Bladder neck descent, which results from a very mobile bladder neck, can often result in a condition known as genuine stress incontinence, GSI, i.e. urine leakage during sneezing, coughing, or increases in abdominal pressure, etc. Interstitial or prolapse of small bowel. This type of vaginal prolapse is caused by the weakening of upper vaginal support system. This condition usually follows a hysterectomy. During this condition, the front and back vagina will separate and allow the small intestines to push against the vagina. Rectoceal or rectal prolapse. When the rectovaginal fascia gives way, the vaginal black wall prolapses, causing a rectoceality. In the condition, the back wall of the vagina weakens and causes the rectal wall to push against the vaginal wall, which creates a bulge. This bulge becomes noticeable usually during the bowel movements. Uterine prolapse. When a group of ligaments called the uterosacral ligaments at the upper portion of the vagina weakens. The condition causes the uterus to fall out of place, which generally causes both the front and back vaginal walls to weaken as well. Vaginal vault prolapse. This type of prolapse usually occurs after a hysterectomy, which involves surgical removal of the uterus. As the ligaments around the uterus act as a support for the outlet of the vagina, this condition occurs after hysterectomy. In this condition, the top of the vagina gradually falls toward the vaginal opening, which causes the walls of the vagina to weaken, and eventually the top of the vagina may protrude outside the body through the vaginal opening. An interstitiality is often accompanied with vaginal vault prolapse. The stages of uterine prolapse are as follows. First degree prolapse, during which the uterus drops into the vaginal lower portion. Second degree prolapse. In this stage, the uterus falls to the level of the opening of the vagina. Third degree prolapse. In this stage, the cervix, located at the bottom of the uterus, sags into the vaginal opening and protrudes outside the body. Fourth degree prolapse. Ultimately, the entire uterus protrudes outside the vagina, which is called a presyndia, or complete prolapse. A lot of women may experience some type of vaginal prolapse during their lifetime, which may occur after menopause, hysterectomy, or childbirth. Generally, women are older than 14 years of age who are more prone to this condition. Most of the women often hesitate to discuss the symptoms of vaginal prolapse with their doctors and do not seek medical treatment. Some women who develop vaginal prolapse do not experience any symptoms. What are the causes of vaginal prolapse? The pelvic viscera, including the vagina as well as the tissues and organs surrounding it within the pelvis, are mainly supported by a network of muscles. The main part of this network of muscles, which is called the levator ani, supports the weight of the pelvic organs. These pelvic organs are usually located above the levator ani and perforate through a muscle to open externally. Additional stabilizing support is provided by the pelvic ligaments and pubocervical fascia. Damage to the levator ani may occur in early life, for example, during childbirth. However, at this stage, a woman's ligaments and fascia may well be sufficient to hide the damage. As you get older, these support systems weaken and deteriorate, and the structure surrounding them, as well as the vagina, may start losing the support and may begin falling out of place. This condition is collectively known as pelvic relaxation. When the weight-bearing or stabilizing networks that hold the vagina in place are weakened or damaged, vaginal prolapse occurs. This condition involves support system for the bladder, rectum, small bowel, uterus, urethra, or a combination of them to lose their stability. The common factors that may lead to the prolapse of vagina are as follows. Menopause. The hormone that helps in maintaining the strength of the pelvic support structures and muscles and tissues is known as estrogen. After menopause, the level of estrogen in a woman's body decreases, and this weakens the support system. Hysterectomy. A hysterectomy involves uterus removal. The prime part of the support structure of the top of the vagina is the uterus. These support structures are usually attached to the top of the vagina to hold the vaginal vault in place. The top of the vaginal vault, may gradually fall towards the vaginal opening without the uterus. This condition is commonly known as vaginal vault prolapse. When the top of the vagina falls out of place, it adds stress on the other ligaments as well. Interococcygeal is also followed by a hysterectomy, which causes herniation of the small intestine downward near the top of the vagina. Childbirth, particularly large babies. During childbirth, tissues, muscles, and ligaments surrounding in and around the vagina are damaged. This is especially caused by trauma to these support structures due to long, difficult labors, large babies, or forceps, or venous deliveries, or vaginal tears which add stress to these networks. Childbirth is most commonly associated with cysticercosis, which involves prolapsing of bladder into the vagina. These usually resolve with conservative measures, but may reappear years later. Some other risk factors associated with vaginal prolapse are obesity, advanced age, dysfunction of the nerves and tissues, and inflammation of the connective tissue disorders, prior pelvic surgery, exhausting physical activity. What are the symptoms of vaginal prolapse? One of the most general symptoms of all types of vaginal prolapse is the sensation that occurs when the structures or tissues within the vagina fall out of place. It is described by some women as a dragging sensation or the feeling that something is coming down. A pressure or protrusion in the area of the sensation may also develop. The severity of the symptoms depends on the advancement of the prolapse. General symptoms observed in all types of vaginal prolapse include the following: painful intercourse, a mass at the vaginal opening, recurrent urinary tract infections, reduction in pain or pressure when a woman lies down. The symptoms that are specific to some types of vaginal prolapse includes constipation, is the most common symptom of a rectococcygeal. Difficulty in emptying the bladder. This is another symptom secondary to an enterococcygeal, cysticercosis, urticoccygeal, vaginal vault prolapse, or prolapsed uterus. Urinary stress incontinence. This is a common symptom which is often accompanied by bladder neck descent. Difficulty in emptying bowel. This problem is symptomatic of vaginal prolapse, an enterococcygeal or rectococcygeal. Extremely painful long periods of standing. This may be symptomatic of a vaginal prolapse, enterocolial, or prolapsed uterus. Protrusion of tissue in the vaginal back wall. This is a common symptom of rectocolial. Protrusion of tissue in the vaginal front wall. This is a common symptom of cystocolial or erythrocolial. Enlarged vaginal opening. This is a physical study frequently observed in combination with vaginal vault prolapse. How is pelvic prolapse diagnosed? For a doctor to make a definite diagnosis of pelvic prolapse, they will need the patient's medical history. They will also need to conduct a detailed physical examination. Each area of the vagina needs to be thoroughly and independently assessed to determine the type and severity of the prolapse. A speculum examination is usually done both on your back and in the left lateral position. You may also need to examine it sitting in an upright position or standing up and straining so that any prolapse which may not be apparent whilst lying down can be confirmed. As well as helping to determine the best treatment for pelvic prolapse, the following tests also help in assessing the anatomy and function of the pelvic floor, as many women with pelvic prolapse also experience urinary incontinence. Bladder function tests. Urodynamics. A diagnostic procedure that helps in testing the ability of the bladder to store and evacuate urine. The first step of its kind is known as uroflowmetry, in which the amount and force of the urine stream are measured. The second step is known as a cystometrogram, which involves insertion of a catheter into the bladder. After this, the bladder is filled with sterile water, and the volume at which the patient develops urgency and fullness are noted. After the measurement of the bladder and urethra, the patient is instructed to cough or bear down to elicit leakage. The information gleaned from this test may help the surgeon in choosing the appropriate type of surgery. A catheter is usually also inserted into the rectum to measure intra-abdominal pressure at the same time. Q-tip test. During this diagnostic test, a small cotton-tipped applicator lubricated with an anesthetic gel is inserted into the urethra. After this, the doctor asks the patient to strain down. If the applicator increases to 30 degrees or above, this may indicate that the urethra descends while straining and indicate anti-incontinence surgery. Pelvic floor strength. In the pelvic examination, the surgeon tests the strength of the pelvic floor and sphincter muscles in women. The doctor also evaluates the strength of the ligaments and muscles in the structure that support the walls of the vagina, rectum, anus, urethra, and bladder. These studies help the doctor to figure out whether the pelvic floor exercises, like Kegel exercises, benefit a woman to restore the strength of the muscles of the pelvic floor. Furthermore, the doctor may use the following imaging test for the diagnostic purposes, if required. Ultrasound. In this diagnostic tool, sound waves are used. When sound waves contact a comparatively dense structure like blood vessel walls and fibrous tissue, they reflect back. These reflected sound waves are then converted into images of the internal structures being studied. This helps doctors investigate women with urinary incontinence and visualize the bladder or kidneys of the muscles surrounding the anus in women with anal incontinence, or to find any masses that might be pushing pelvic organs down. Magnetic resonance images, or MRI scans. In this imaging tool, a powerful magnet is used to stimulate the tissues within the pelvis. These tissues then produce a signal, which is evaluated by using a computer. As a result, a 3D image of the pelvis is then produced on the screen of the computer by using these signals. Arthroscopy. The cystoscope, which is a small tube-like instrument, is lubricated with an anesthetic gel before being inserted into the urethra. The light and camera present in the cystoscope allow doctors to visualize the inside of the bladder and urethra on a television screen. With this procedure, doctors are able to investigate women with symptoms of frequency, urinary urgency, bladder pain, or bleeding during urination. How is pelvic prolapse treated? The factors that determine the best treatment are whether or not the patient is sexually active. If sexually active, non-surgical options may be more appropriate. If less sexually active, surgical repair is the most suitable option. Recurrence rates are still high. Patient's age. Patient's overall medical history. Women who cannot undergo surgery for medical reasons or who develop no significant symptoms related to this condition may opt for non-surgical options. Patient's childbearing plans. patient's personal preference. The procedures her gynecologist is most comfortable with and feels has the best results. Pelvic floor physiotherapy. 3 out of 5 patients can avoid surgery with pelvic floor physiotherapy. Patients undergoing surgery are strongly advised to see a pelvic floor physiotherapist. Surgery is pointless if the patient doesn't perform pelvic floor exercise afterwards. I liken this to a hammock tied between 2 trees. I can tighten the hammock, i.e. the sister cell or restor cell, etc., but can do nothing about the trees, the levator ani muscles. If the trees weaken, you will still suffer a recurrence of your prolapse. Self-care for vaginal prolapse at home. Pessary, a small device made up of soft plastic or rubber. It is usually placed inside the vagina to act as a support. There are different varieties of pessaries available for correction or prolapsed vagina. For women who are not sexually active or cannot undergo a surgery for medical reasons, pessaries must be removed and cleaned regularly. To avoid infections and vaginal wall erosion, estrogen creams are commonly used with the pessaries. Activity and behavior modification. Patients with vaginal prolapse that causes minor or no symptoms should avoid heavy lifting or straining. Kegel exercises. Kegel exercises help in tightening the muscles of the pelvic floor. These exercises can be tried to correct mild to moderate cases of vaginal prolapse or to supplement the other treatments used for severe prolapses. Electrical stimulation. To treat pelvic prolapse, doctors or physiotherapists can apply a probe to the targeted muscles within the vagina or on the pelvic floor. The probe is generally hooked up to a device that assesses and delivers small electrical currents which contracts the muscles. These contractions help to enhance the strength of the muscles. And electrical stimulation, which is less intrusive, is also available. It magnetically stimulates the nerves that supply those pelvic floor muscles from the exterior of the body. This activates these nerves and may help to correct incontinence. Biofeedback. In this sense, a sensor is used to control the activity in the vagina and on the pelvic floor. The doctor physiotherapist can suggest exercises that may assist women to strengthen these muscles. During the exercises, the sensor can monitor the muscular contractions, and the doctor may be able to decide if the targeted muscles would benefit from the exercises. Medical treatment for pelvic prolapse. Hormone replacement therapy. Estrogen helps in strengthening and maintaining the muscles in the pelvis. However, the advantages and risks of the estrogen therapy must be weighed for each individual patient before selecting an appropriate hormone therapy for other indications. The Mona Lisa touch. This is a radical new treatment for some symptoms of very early prolapse. A carbon dioxide fractional laser is used and improves the elasticity and tone of the vaginal wall. This can be combined with physiotherapy to give better results.